So I wanted to make bring up something about the transplant service, and Sathvika might know about this from another way, but her husband's a transplant fellow here. But we are being asked to help with the solid organ transplant patients. This is Gen Med, non-teaching hospitalists. And it will be after hours, holidays, and weekends coverage. And you'll receive some special training for that. This is just new, all new. None of you knew about this from the interview process, I'm sure, because I just found out about it myself. And it will start in about 4 to 6 weeks. They have some things to work out. So the transplant services, this is only, right now we're just talking about solid organ transplant, kidney, liver, and rarely we have simultaneous pancreas and kidney. They are going through some changes. They're the medical, what I would call a medical transplant patient, that is a patient who's not fresh surgery patient, who just had a transplant, or who is in the hospital for a surgical complication of a recent transplant. So if they got their surgery, they got discharged, now they're back with a wound dehiscence or a wound infection. That's not us. From now on, I'm just talking about what I would call medical transplant. So, patient had their transplant a year ago. Now they're having an infection. They're immunocompromised. They have medications on board. They may be having a complication of their meds, or they're having rejection. We're going to start helping with those patients, and they won't be completely ready for that, because they have to have a day crew in place, and the day crew will be a combination of fellows, faculty members, and PAs. All right, so they have to hire the PAs and train them, and go, have them get some on-the-job training for a few weeks. So once that starts, and I'll tell you more when we get closer to that. They'll be handing off patients to you. You'll go to their rounds in the morning, and so on. In the meantime, though, what's critically important is that that those same patients, are being distributed amongst all the 5 Gen Med services. This will be pertinent to you, Rachel. So they're just going anywhere right now. They don't have a day crew. There's no special night coverage. They're just like any other general medicine patient. Does that make sense? So for right now, it's really been confusing around the medical center, because some people thought we were going to start it today, July 2nd, but it just flopped for today. It's going to be put off. I know this might be confusing because you haven't heard about any of these patients yet, but as soon as you have your first shift, they'll be calling you like, well, where's, come on, this is a Gen Med, this is a hospitalist patient, but it's not until after. And even then, it's only coverage. It's not, we're not going to do the rounds on those patients or anything like that.
Can we just admit them after this?
If you, assuming after this new program starts in 4 to 6 weeks, if the patient comes in after hours, you would admit them, and the next morning turn them over to what I call the day crew, which is a specific transplant service. It'll be a transplant hepatologist for the liver transplant patients, or a transplant nephrologist, very specific. They've gotten so specialized that that's all they do. Maybe with a fellow, and almost always with a PA. And the PAs will have, they'll be taking care of the patient during your 10-hour day shift. The daytime hospitalists don't touch these patients, so they have to have coverage for 10 hours. And so the PAs, they don't work 10 hours, they work 8 hours. So they're going to split their shifts, That's another thing they still have to work out. So you would admit them at night. They'll teach you, they'll get you all trained. You'll call the transplant nephrologist or transplant hepatologist 100%. The faculty want to be called with every admission. And then you'll hand them off to the team the next day. You don't follow them. Yeah.
And are we talking about all transplant, like even somebody who had its kidney 10 years ago and coming now with,
yes,
I don't know, pneumonia?
Yeah, the criteria will be post-transplant anytime.
Okay.
Anytime in the past, a kidney or liver or pancreas. They will also include pre-liver if they're listed.
Okay.
Kidney does not have that. I don't know exactly how that, but they will not be admitting pre-transplant kidney patients to this medical transplant service. I can imagine a gray area would be patient had a failed organ. Of course, if they don't have a liver, they're dead. But if they have a failed kidney and they're on dialysis, we have traditionally gotten those on Gen Med, aside from transplant. I'm not sure what we're going to do with those yet. The transplant patients will be preferentially admitted to 2 Carver, and they'll actually be admitted to the transplant service, even if you do it. They'll be admitted to the transplant service for various reasons. But so yeah.
We need to call for the attending
Every time, every patient, and they may be calling you if they have received. We're not sure how the triage is going to go. You won't have the triage responsibility for this patient. It might be a fellow or a PA or a faculty member or all. It might rotate it. So it might be that the faculty member is calling you and say, this, here's the patient. I want you to call me after you evaluate. Or they might say, no need to call me unless you have a question, But there'll be a phone contact with every patient. That's our plan for it. That'll be for at least the near future, And maybe later, if everybody's real familiar and it's going well, we might dial that back a little bit. And then a year from now, we hope that we'll have a full hospitalist service for transplant, that we'll have a 24/7 hospitalist. That'll be one, it'll be one FTE, so to speak, one day and one night hospitalist trading off week on, week off, just like we do now, except there'll be only one. And we have 2 now for Gen Med, 2 for cardiovascular, and 2 for Hem-Onc.
So you only know the transplant patient of University of Iowa or anywhere?
Well, that's a good question too. If they got their transplant somewhere else, the transplant service here is not real hot on taking care of those patients. That's a really good point. You're very perceptive.
Whom are you going to call them?
I don't know. That's a good one. I'll have to work on that. They've been on Gen Med before, and then the transplant physicians have come and given advice about their immunosuppressive drugs, but and then try to get them back to their home, assuming they don't want to transfer their care here. If they've been transplanted at Mayo or Chicago somewhere, we try to get them back. We've even called while they've been in hospital and say, hey, what do you want us to do here and stuff. But I'll have to work on that one. That's a good question. What else about that? All right. So let's see. What's on for this afternoon? Rapid response team. You all are not part of the rapid response team, and you're not part of the code team. Okay. The rapid response team is made up of 3 individuals. It's the senior medicine resident on call for all medicine floors. That would include neurology and things like that. Or the senior surgery resident on call for any surgical floors, including ENT, OBGYN, transplant surgery, etc. So there's one physician. There's a senior nurse who doesn't have patient care responsibilities, who is a critical care nurse. So his or her role is to know where the beds are available. So we might have a patient we want to transfer to medical ICU, but they're full. So this person knows surgical ICU or cardiovascular ICU has a certain number of open beds. Number 3 is a senior respiratory therapist who has no other patient care responsibilities, and their role would be to provide supplemental oxygen, draw blood gas, give a breathing treatment, albuterol neb, something like that. So the RRT team, the 3 individuals will come to the room and they will advise the primary team. If the primary team is not there, if they're in the OR or they're busy, then they'll take over. But it's still their patient, the primary team, or in case of your patient, this is still your patient, you're in charge, they cannot supersede your orders, your wishes. But they're there to advise you and help you and to do it very fast. The American data are not very good for these RRTs. It has not shown improvements, but the worldwide data, these started in Australia, and the worldwide data is very positive, and our data is very positive. A very good marker for this would be, I helped set up the RRT with John Fieselman, and a marker would be how many codes happen on the floor. And the code, when we started the rapid response team, Code Blue rates went way down. And you could say, well, they just coded the unit, but It's much better to code in the unit, believe me. The right personnel are there, the nurse is right there with the patient generally. So the patient's distress is recognized much quicker than there would be on the floor. And in fact, the survival to meaningful recovery outside the hospital for patients who code in the ICU setting is like 40 to 50%, and for medical floors, including ours when we studied it, or other medical floors like ours, is somewhere around 10% or less. It's very low. So the rapid response team is a good thing. We should not be impeding the calling of a rapid response. If a nurse says, I want to call it, don't say no. We don't want you to stop that process. Don't feel like they're criticizing you or countermanding you or something. They are there to help you. You can call the rapid response team. I've done it myself personally a number of times. The criteria, I don't have them in my head, but it's just abnormal vital signs. 2 abnormal vital signs would allow you to call the rapid response team. And there's one criteria, how is it, do you remember how it's worded? The unsurety about the patient's condition or something like that. It's anything, And actually we want you and the nurses to develop those instincts. It's you walk through the door and something's not right. Something doesn't look right. It might be that the patient is paradoxical, or they're tachypnic, or they're cyanotic, they're diaphoretic. You might not be able to say, "Oh, they're cyanotic. I need to do something." It might be, well, it doesn't look right, or it might be a patient you've never seen before, and you can't tell if they might be cyanotic, but maybe they're always like that, So in other words, any abnormal vital sign is good enough to call the rapid response team. Yeah, please. Yeah.
So let's say, I'm looking at the patient, his vitals are stable, but I'm looking at his respiratory rate is about 40, and I think he might need intubation. Do I still need I'll just call the anesthetist and the ICU team, or do I still?
Depends on how unstable they are. So, if you think that you have time to call the medical ICU fellow, the critical care fellow, and say, I need this patient transferred, it's going to take some time. They might be full. They might want to do a bedside evaluation. Even if they say, send them up, there's a nursing report, there's the moving. So if you think the patient is okay for another half hour, then you can transfer them without the rapid response team. If you think that you need somebody else at the bedside, this would be a good role for the rapid response team. If you need somebody to stand in that room while you're calling the critical care fellow, that's a good time to call. That'd be another trigger. If you think the patient cannot survive to the unit, they need to be intubated in the room, that's a code. So what we do here is we call a code blue for that, because that's when we get the anesthesiologist to come. Yeah. So anesthesia is not part of the rapid response team. Let me come back to that rapid respiratory rate thing in a minute, but just briefly about the code team. You're not part of the code team, but again, it's your patient. You can participate. It'll be senior medicine resident for every patient, senior nurse, number of nurses will come, respiratory therapist, anesthesiology, and a resident from surgery. The surgery resident is there to place a line if you want it. And as you know from ACLS, placing a central line is not part of the first few steps of ACLS, so you can just tell them, just hold off. If you have a good peripheral IV, actually there's data that using a peripheral IV in code in ACLS is better than central line, taking the time out and stopping CPR and all the above. But it's, it's still your patient. You might, during that code, even though the senior medicine resident is in charge of the code technically, that might be a time for you to talk to the family if things are going badly, since you may have had, you almost for sure would have had contact with the patient's family. You might be the one to escort them into the room if this thing is really going bad, or be calling them or going out to a waiting room to talk to the family, or you can help the resident, you can assist them, train them, say, hey, maybe you ought to think about this. But we want the residents to run this code. If they're blowing it, of course, talk, speak up, and that's the same for anybody on the team. Let's see. So the rapid response, I just wanted to mention the rapid respiratory rate during the rapid response or not. John Fieselman, the guy who's in charge of this, both Code Blue and rapid response team, he studied this in this hospital, and so he has reviewed every death in this hospital since he came here about 20 years ago. It's a lot of work. And he was trying to prevent deaths, of patients in hospital. And of course they take out patients who are on hospice or have terminal cancer or terminal heart failure or whatever. But unplanned deaths or surprise deaths in hospital, he did regressive analyses on those, and he put in all white counts and temperature and their EKG findings and all kinds of many different parameters. And one thing kept falling out consistently was the respiratory rates. Respiratory rates over 26 or 27, depending on when he did the study, what time period. And so he decided to do the experiment, and this was probably about maybe 12, 13 years ago. They did on our floor on 6 Carver. Anytime a patient had a respiratory rate of 26 or greater, that it prompted a response, not a rapid response. We didn't have that back then, but the house staff had to be called and they had to evaluate the patient. It required a bedside evaluation, night or day. And when they did that during the 3 years of the study on 6 Carver, actually it was started before medical patients were on 6 Carver. They were on 3 Boyd Tower. But during the time of the study, Code Blue rate on that floor, none. Not one code happened on the medical floor during the time of the study. And this kind of led to this hospital's impetus to do the rapid response. And it was at the same, in Australia, like I said, the same thing was developing. So, so I would commend that to you as a marker for illness. You probably have already gained some experience with that in your training and other places you've worked, but that's a very potent marker. And it's variable. I mean, it's not going to be 100%. So I've had a patient who, we went in to see them and their respiratory rate was 40, and we did blood gas and we did some chest x-ray and EKG and did an evaluation, couldn't figure out what was going on, transferred them to the unit. Next morning they came back, nope, nothing happened. Maybe it was anxiety, I'm not sure. So the critical care units, the critical care fellows here, they know that we do this. They know that there may be a patient who the only abnormality after bedside, rapid evaluation on the floor, the only thing that they have is an increased respiratory rate. They will take them. They will take them to the unit and observe them. And even if they don't require intubation or BiPAP or whatever, What else about that? Any other questions? The critical care fellows will work with you. They may say, I'm not sure that patient needs the unit. Why don't I come see? And they'll go with you and to see the patient. And they may say, well, why don't we try these few things over the next half hour to an hour or whatever. And if you're still uncomfortable taking care of that patient on the floor after that, they'll take them. And if once in a while our doctors have called the staff, the medical ICU staff, or called me. But usually the fellows are real good about taking patients, and even if it's if you're uncomfortable, you're nervous, the nurse is nervous, they'll take them,
Anesthesia does all the intubations?
Preferentially here, yeah. Pulmonary fellows get experience in the unit and in the operating room, so they normally don't do it during codes. I have mixed feelings about that personally, but I guess it doesn't matter. Yeah. You want to get somebody experienced, the best person you can to do it. But I've done a lot of them myself, so. What else? Any other issues? Wrap up for the day. Anything else about the other sessions? Oh, I was going to give you a billing, but any questions? So you had a talk about billing. What would they focus on? Did they focus on how to code them or levels or?
Detailed stuff is tomorrow.
Oh, I know, but didn't you have something today?
JT just came by and said,
Okay,
available.
and where to do your billing. So I'll just give you a primer on this, but don't tell anybody. I wish it wasn't being recorded. But a patient who is admitted to the hospital and has one or more medical problems, that's a high. That's a 5. So the codes are, I forget what the first 4 digits are, but the last digits are 1 through 5. 1 being the lowest level, 5 being the highest. A 1 would be like admitted by a PA or nurse practitioner. I mean, we would never use that. We would generally use 3, 4, and 5. A 3 to me is somebody who I just admitted a week ago. It's a readmission. But anybody who has 1 or more medical problems, they're sick enough to be in the hospital, that's a 5. Full H&P, everything, you or your residents perform a full H&P with reviews, everything, family history, social history, review systems, full exam, that's a 5. In terms of your daily charges, your daily notes, your daily visits and rounds, it's 1, 2, and 3, the last digit. And a 3 would be, patient sick, they have issues, you ordered tests, you ordered medications, you ordered consultations. That's a 3. Patients waiting for nursing home placement, that's a 1. 2 would be, patient's stable, we really didn't change anything today, but they're not really nursing home bound patient, that's a 2. All right, and we'll show you, I think tomorrow we'll show you our actual distribution of our codes, so what our hospitalists actually bill, and we'll show you how it compares nationally. Also, the discharge, there are 2 codes for discharge. Have any of you had experience with billing like this? I don't know why we protect residents from this, and I don't know why, but there are 2 codes for billing. Yeah, did you? Okay, yeah, this is different. The discharge is billed 2 different levels, and they're based on time. And one is over 30 minutes and one is less than 30 minutes. And the time does not have to be face-to-face time in the patient or with the patient or in the patient's room. So it includes time that you spend with the patient on the discharge day, time with the family, time on the phone if you call the referring doctor or consultant, time with the social worker, etc. So it includes all that. And so, a complicated patient who you spent a lot, medication reconciliation, you made some plans, they have outpatient antibiotics or outpatient CVN, TPN or something like that. That will almost for sure take you over 30 minutes. So, and you can bill for that. And you just have to, in your note, you just have to document, I spent over 30 minutes talking to blah, blah, blah. And there is a template that I can give you access to that I've written for that. It's .londc, I think. But I think we have to grant you sharing privileges, but we'll take care of that. So you just hit .lon and that comes in, and you just check that box. I think you'll find a lot of your discharges are that way. Yeah, when the billing and coding people come, they'll run you through this whole thing that's like a very complicated algorithm, and it's hard to understand at first. And so you might just get a general understanding of that for now and use what I'm telling you for a little while. But I think at some point it's very helpful to go back over that and actually to audit yourself. If she gives you a handout, make 10 copies of it and go through and audit your charts sometime and see if you know how your coding is, if it could have been higher or lower. we don't want you to upcode or commit any kind of fraud, you know what I mean? In fact, that's what the meetings with people are about. It's their obligation to make sure that we are not fraudulent in our billing and coding. And so, you know, of course, the federal government is very much on that. You know, there's new Medicare impetus, new funding to prevent fraud, you know, committing fraud on Medicare patients. So don't be afraid of it, but just do honest coding, and we want you to get paid for what you do. You get paid for the work that you do, you know. Well, anything else?
Is there any way you can access Epic at home?
Yes. Actually, I meant to mention that when Eric was here. You can access Epic. You can access that schedule, the shared drives. If you have teaching materials, you can access from the internet. And it's desktop.healthcare.uiowa.edu. Got it?
The desktop.
Desktop.healthcare.uiowa.edu. UIOWA, yeah. Desktop. You got it? Yeah. Desktop.healthcare.uiowa.edu. And then once you get on that, you have to download a plugin from Citrix, unless you already have that for some reason. And I think you have to have an account. So we'll ask Kristen to make accounts for all of you to access that. You already have it.
I have it. I don't know if we need to renew it. They gave us some.
No, I don't think so.
We get a paper actually.
I think we
Yeah, there is an
the remote
application.
access.
Okay. Oh, maybe that is that. Is that? Yeah, that
That's
is
the
it.
remote access. And
Yeah, that is it. Okay.
Now, long distance, does that include? Is that? Do you know if that's?
I'm not sure. You guys will have a long distance code. We'll just have to ask Kristen. So that if you make a long distance call from here related to the hospital business, it's free, you know. What else?
For the long distance, we just ask the operator to connect, right?
No, it's you dial the number, and then you'll hear a tone, and then you dial in your 6-digit code. It's worth memorizing. You'll use it often to talk to referring doctors and patients.
What's
Yeah.
long distance? No, by that I mean within Iowa.
Either.
That
Either.
doesn't matter.
Yeah. Either within Iowa or outside the state, outside the area code. It's the same code. Yeah. I'll get those for you.